We've had decades of public health campaigns, incredible advancements in surgery, regular screening, and yet the question hangs in the air. Why does breast cancer still claim so many lives? It really feels like a paradox.
It truly is.
Hmm.
I mean, our sources confirm a massive victory on one front. Regular screening and modern treatment have cut breast cancer deaths by about 50% in screened women.
Which is incredible.
It is.
Mm.
That success proves early detection works for certain types of cancer.
Right, but that also means half the battle is still being lost. That other half the people we can't save, even when we find their cancer early, that suggests we're not dealing with a single disease. We're dealing with these highly dangerous forms that we just haven't learned to classify correctly.
And that is exactly what we're diving into today. Our source material is a detailed 2023 investigation. It looked at over 2,400 breast cancer cases to try and solve this exact problem.
Okay, so what's our mission here?
Our mission is to uncover the fundamental differences based on what's called the tumor growth pattern. Specifically, why a cancer that forms a neat single lump is just radically different from one that's multifocal or diffuse.
And here's the statistic that just stopped me in my tracks, and it explains why this is so urgent. The research found that a minority of cases, just 45% of the total, are responsible for the vast majority of deaths.
A staggering 71% of all fatalities.
Wow.
We're diving into that deadly 45%. Because if we keep treating these aggressive cancers with old, inadequate terminology, that fatality rate is not going to change.
So we need a fundamental shift.
A huge shift in diagnosis and management to actually move the survival curve for these patients.
Okay, let's unpack this. For so long, the approach has been to treat breast cancer as a single tumor mass that just needs to be removed.
Right.
But this research says we have to abandon that. We need to start classifying it based on two things: tumor growth pattern and its apparent site of origin.
Exactly. The researchers used advanced imaging to basically classify 4 distinct groups based on where they started and how they grow.
Yeah.
Some new terminology, but the distinctions are absolutely critical for understanding the risks.
Okay, let's break them down. Let's start with the most common one, which is, thankfully, the least aggressive.
So group 1 is our baseline. It's called ascinar adenocarcinoma of the breast, unifocal, we'll just say AAB, unifocal.
Okay.
This is the majority, about 55% of all cases. It starts in the little milk-producing glands, and crucially, it presents as a single contained mass, so it has the best prognosis. Its fatality rate is about 6.1%.
So this is the contained threat, a neat tumor that screening and surgery can often handle really well. But then we move to group 2, and the risk more than doubles, even though it's the same exact cell type.
Right. Group 2 is AAB, multifocal. So same cancer, but now you have multiple distinct spots of it in the breast. It's not one lump. It's 2, 3, maybe more separate little lumps.
And just that fact that it's in multiple places is what drives the fatality rate up to 13.1%.
It is. It's all about the biology and the total disease burden, multifocality.
Yeah.
It just signals a more pervasive threat. It means the cancer is already showing it can seed and spread locally.
Okay, now we get into the really deadly categories, the diffuse or spreading subtypes that kind of hide in plain sight.
So now we shift from AAB to 2 new origins. Group 3 is DAB diffuse. That's ductal adenocarcinoma of the breast. This one originates from the major milk ducts.
And it doesn't form a lump.
No, not a defined lump. It spreads out, filling and extending along those duct structures. And that growth pattern explains its very high fatality rate of 24%.
And then we get to the absolute worst case scenario.
That would be Group 4, BCMO diffuse, or breast cancer of mesenchymal hybrid cell origin. This is what's conventionally known as invasive lobular carcinoma. It's a different beast. It often starts from a different cell type entirely, which gives it this extremely aggressive, stealthy behavior.
And the fatality rate for that?
A crushing 33.7%.
The survival data really puts this in perspective. So if the unifocal AAB, the first one, is our reference point with a hazard ratio of 1,
Right.
multifocal AAB immediately jumps that risk to 2.25. DAB, the one spreading in the ducts, it shoots up to an HR 4.35.
And then BCMO, that mesenchymal hybrid, carries the highest risk of all, a hazard ratio of 6.69.
So you're over 6.5 times more likely to die from your disease compared to the patient with the most common contained type.
That's what the data shows. It's a massive difference in risk.
What's really sobering here is that the sources stress that even with mammography and earlier diagnosis, the frequency of these fatal multifocal and diffuse cancers hasn't gone down.
Not at all.
We're finding them, but they're still occurring at the same deadly rates. Which tells me the problem isn't just detection, it's what we do after we detect it. It's about classification and management.
Precisely. If finding them isn't enough, we have to look at what happens between the diagnosis and the treatment. And that brings us to what the researchers call the burden of disease.
Okay, let's focus on that multifocality issue first. We said that women with multifocal AAB have much poorer survival, even when you control for things like tumor size and grade.
Yeah, the data is it's crystal clear on this. Multifocality is an independent negative prognostic factor. And the key phrase to remember is greater total tumor burden.
Right.
Think about fighting a fire. It doesn't matter if it's one huge blaze or 10 smaller separate ones. The total heat, the total area being consumed, that's what matters.
So the current system is effectively measuring the height of the largest flame, not the total area of the wildfire.
That is a perfect analogy, and this is where we hit a massive systemic pitfall in cancer staging. It's called the TNM policy.
The tumor node metastasis classification, the gold standard for staging.
The standard, yes. And here's the problem. For multifocal cancer, the TNM system relies only on the diameter of the single largest invasive focus.
Wait, just the biggest one? So if you have 7 little tumors, they only measure the one?
They only measure the biggest one. And that practice, it severely underestimates the actual extent of the disease. It's a huge blind spot.
So why is that still the policy? Is there institutional resistance to changing something so fundamental?
There is. It's rooted in long-established guidelines that, prefer the simplicity of measuring one dominant mass. But the researchers are clear. This underestimation directly leads to poor outcomes. Because treatment intensity, chemo, radiation, surgery, it's all based on a dangerously incorrect assessment of the true disease burden.
We're consistently treating a massive problem like it's a medium-sized one.
That's it, exactly. Which is why the research just stresses this urgent need for multimodality imaging. We're talking MRI, ultrasound, tools to reliably see the full extent of the disease before surgery.
Okay, let's shift to those 2 truly fatal diffuse subtypes. Why are they so dangerous? Let's start with DAB, the one that spreads along the ducts.
What's fascinating here is how it spreads. It uses something called neoductgenesis. The cancer cells are actually forming new, invading duct-like structures.
So they don't form a neat ball.
No, they grow like roots, pushing through soil, just establishing these complex invasive networks.
Can you help us visualize that? Is it less like a solid potato and more like a network of invasive ivy pushing through the walls of a house?
The ivy analogy is perfect. And that growth means you have this massive tumor burden that's all spread out. And often there's no solid palpable mass. You can't feel it easily, and a standard mammogram might miss its true extent.
But the real danger, according to the source, is how our medical system labels this thing.
Yes, this is the crucial diagnostic conflict. Current terminology often classifies this invasive cancer as ductal carcinoma in situ, or DCIS. And the researchers say that label is actively and profoundly detrimental.
Why is calling an invasive cancer in situ, which means contained, so bad? That sounds like a clinical catastrophe waiting to happen.
It is a catastrophe because that classification dictates the entire treatment pathway. If it's labeled in situ, standard pathology guidelines often don't recommend doing crucial HER2 staining on that component.
Because the assumption is in situ disease doesn't need aggressive targeted therapy.
Right. And if that staining isn't done, the patient might never even be considered for life-saving treatments like Herceptin, even if their cancer is highly HER2 positive.
So an outdated, inaccurate name literally blocks a patient from getting a drug that could save their life.
Correct. It leads directly to tragic underdiagnosis and undertreatment, and that contributes directly to that 24% fatality rate we talked about.
That is a massive systemic failure, and it's rooted in language. Now, what about the most dangerous one of all, BCMO? The one with the 6.5 times higher risk.
Right, the one conventionally called invasive lobular carcinoma. This one is known for being stealthy. It causes what's called architectural distortion rather than forming an obvious lump.
So it's not only invasive and diffuse, it's also hard to spot in the first place.
Exactly. And here's the ultimate deception. Its standard immunohistochemical biomarkers, the things we test for, often deceptively indicate a very favorable long-term prognosis.
Wait, so the internal chemical signals of the cancer? They look mild, when in fact it's a raging inferno.
Precisely. That favorable biomarker profile can adversely influence management decisions for what is, in fact, the single most aggressive cancer we've discussed. The pathologist, the oncologist, they might be reassured by the numbers on the paper.
And they might dial back the treatment intensity.
Which is a fatal mistake. given the 33.7% fatality rate.
So if we connect all this, for all these deadly subtypes, success hinges entirely on the diagnostic team stopping the single mass thinking, and starting to think about the entire diffuse region of disease.
That is why the source material concludes that integrated diagnostics are essential. The images they show of these extensive DAB and BCMO tumors make it clear. You need comprehensive preoperative imaging, especially MRI, to see the full breadth of the cancer before you even think about surgery.
So if identifying these cancers is so complex and our current terminology is actively detrimental, what is the path forward? It sounds like it's less about a new wonder drug and more about improving technology and maybe even more importantly, communication.
That is the heart of the matter. The conclusion is a call for better interdisciplinary communication and advanced diagnostic tools. They say these things are non-negotiable for improving outcomes.
Okay, let's focus on the tech first. What tools need to become standard of care that aren't right now?
First is the multimodality imaging we mentioned, using breast MRI or contrast-enhanced mammography before surgery. Standard mammograms can miss the full extent, but these advanced techniques can map the entire battlefield, which is key for planning the surgery.
And the second tool is about determining the origin, which predicts the outcome.
Yes. Routinely integrating imaging biomarkers to figure out the tumor site of origin AB, DAB, or BCMO. That site, which you can see on imaging, is a proven predictor of the outcome. We don't have to wait for the post-op pathology to realize we're dealing with a 6 times greater threat.
And the third tool sounds like the final quality check to make sure nothing was left behind.
That's image-guided large-format histopathology. This is basically turning the removed tissue into a complete high-resolution map. The pathologist uses these huge, thin sections of the tissue, scanned at microscopic resolution.
So they can line it up exactly with the MRI from before the surgery.
Exactly. It lets them correlate what they're seeing under the microscope with the preoperative imaging, assess the total tumor extent, and confirm the surgical margins are completely clear across the entire complex region.
But the systemic fix, closing what the source calls that unnecessary yet commonplace information gap, that sounds like the hardest part.
It might be the most crucial. The research highlights the need for seamless communication between the imager, the surgeon, and the pathologist. For instance, the pathologist needs to get the full imaging workup, the mammograms, the MRI, at the same time they get the specimen.
So they aren't just looking at a piece of tissue in a vacuum. They have the complete pre-treatment map of the disease to compare it against.
Precisely. They are verifying the extent, not just confirming the presence. The goal, as the researchers stress, is to use these pre-treatment planning conferences as the golden opportunity for the whole team, radiology, surgery, oncology, pathology, to look at the unified picture.
And avoid the extremes of underdiagnosis and undertreatment that are costing lives.
That's the goal.
This has been a really illuminating deep dive, so let's recap the core takeaway for you, the listener. Breast cancer fatality is highly concentrated in these specific, complex growth patterns, multifocal AEB, DAB, and BCMO.
And treating these successfully relies less on discovering some brand new therapy and infinitely more on correctly diagnosing the full extent, the true burden of the disease, using this integrated approach across imaging and pathology. It's a failure of system and classification, not necessarily a failure of therapy.
Right. So the key to improving survival for that vulnerable 45% of patients isn't just finding the cancer earlier. It's making sure that once it is found, the entire team uses every single tool, from MRI to large format histopathology, to define and treat the true burden of the disease.
And here's a provocative thought for you to take away from this. The current reliance on histopathologic terminology developed decades ago, like calling an aggressive, invasive lesion in situ, is actively detrimental to patient survival today. So you should consider, how might outdated diagnostic language in other complex medical fields also be unintentionally masking life and death severity? And what systemic changes are needed to force our terminology to finally catch up with our incredible imaging capabilities?